Hello friends, I am Dr. Ankit Madharia. I am an orthopedic surgeon and an endoscopic spine surgeon, and today I am going to demonstrate how I do a transforaminal endoscopic decompression of lumbar canal stenosis. Today our case is a 42-year-old male who has complaints of back pain and left lower limb pain since past 5 years. His pain has increased since past 6 months, and the claudication distance at present is 50 meters. We have been trying conservative management for him for past 6 months, but he's not quite happy with the results. So we have decided to do a decompression surgery for him. These are his MRI, and I'm going to go through his MRI in detail, and I'm going to tell you what my plan is. So if you can see in this sagittal cuts, he has a bulging disc at L4, L5 level, that is more on the left side. If we see this axial cuts, you can notice that he has a ligament, lumbar canal stenosis at this level, where the disc has been bulging and this foramen has been completely closed by this bulging disc. Also, there is some ligamentum flavum hypertrophy in this region on the under surface of the facet joints, and that is mainly the cause of complaints in this patient. So you can see that traversing root over here is mainly compressed by this bulging disc and this part of ligamentum flavum. Now I need to stress here that by the three zone and three wall concept, the ligamentum flavum lies on just the inner surface of the facet right over here, that is the main cause of stenosis. The posterior structures like this ligamentum flavum are not much responsible for causing symptoms to the patient. So by going through that concept, my plan would be just to decompress this part of disc. So I'll be decompressing the disc, I'll be removing this part of disc, as well as I'll be working on the facets. So just I'll tell you what is the three wall three zone concept. Three wall three zone concept divides the spinal canal into three zones, that is upper zone, middle zone and lower zone. The middle zone is the disc zone. Anything above that, superior to that is upper zone, and lower to that is inferior zone. So in our case, there's no problem in the upper zone. In the middle zone, there's problem, that is there's a facet related changes. There's a uh, there's ligamentum flavum hypertrophy on the under surface of the facet, and that there are some osteophytes on the inner surface of facets also that I'll be removing in my surgery. So in the middle zone, what we'll be looking at, we'll clearing this facet related changes. We'll be clearing the disc bulge that we can see. This is a disc bulge that we'll need to clear. And the third thing is foraminal G knot and soft tissues. There's not much of tissue right here. The foraminal G knot is actually the amalgamation of soft tissue at the tip of SAP. So we'll be removing that also. That will help us clear the axilla. So that will be basically our plan to grow from the left side transforaminal, and we'll need to clear this part of disc and the facet and the under surface, that is the ligamentum flavum lying here. And after doing that, our traversing root over here would be decompressed. There are some in the lower zone also, there are some features that we'll have to look at, that is the ventral surfaces that will be compressing the traversing nerve. Now these are the things that we mostly neglect when we are doing an open surgery. Now if you look here, that there is a bulging disc lying inferior to the disc level, so there will be some osteophytes over here which would be compressing the traversing root. So I'll be demonstrating how I'll decompress the ventral surface of the dura in the lower zone. Dorsally there's not much compression, so I'll not go dorsal to the dura, and there's no facet cyst. So basically my target would be facet related changes, disc bulge, foraminal knot and ventral to traversing nerve in the lower zone. And these are all the four structures that I would be targeting, and all other structures I will not look at, because I know that only these are the structures that are causing stenosis in this patient. Now looking at the patient's intra-op pictures, in the CM view at the disc level, there was a high iliac crest. So I had to modify my trajectory to go above the iliac crest. So I am going a little bit oblique, not at the level of the disc. In this lateral view, you can see that I have inserted my needle little oblique, which is going above the iliac crest, and I have landed just kissing the facet joints. Now, whenever we are doing a stenosis surgery, we must remember that we need to be very close to the facet joints, and we must always land at the facet, just kiss it and go underneath the facet joints. What the procedure that I do would be an inside out technique in which we first go into the disc and then come out and work on the facets. I had advanced my needle up to the disc level. Then I have changed the needle with a guide wire, and over the guide wire I have created a track with a dilator. Now at this point, usually I would put my dilator into the disc, but in this case I wanted to work first on the facets. So I have removed the dilator and I have inserted a reamer. Now this reamer would go over the guide wire and would ream the under surface of the facets. I have sequentially increased the size of reamer, and gradually we have started working and removing part of the facets, and some part of the disc also has been loosened up by this reamer, and we have gradually increased the reamer from 4 mm up to 8 mm. Once the reaming is complete, we have changed our reamer to this cannula and dilator, and in the lateral view you can see that my cannula is just lying subannular in the lateral view, and it is going up to the midline in AP view. So that is a fairly good position for dealing this case. And now I'll be showing you the endoscopic picture of how I have done this case. So this is the endoscopic picture of after I enter the disc. The mostly things that I see is the disc materials lying subannular. As soon as I have removed those disc material, I withdraw my cannula to see the edge of the annulus. Now, in case of stenosis surgery, I always want to cut the annulus because it is a bulging disc and I want to remove it completely. As I reach the edge of annulus, you can see there's the disc and the facet are completely in contact. I am unable to find any plane between these structures. So I use my radio frequency probe to ablate this edge of the annulus. You can see the facet joint with the ligamentum fleum is lying above, and this is the edge of annulus which I am ablating with my radio frequency probe. Now this is a plasma cautery. It is very powerful. And it has to be used with caution when we are working near the nerve. But since I am lying in the foramen, I am far away from the nerve. Uh, I am just ablating and creating a plane. To orient you, I am doing this surgery from the left side. So our 9 o'clock would be towards the head, and 3 o'clock would be towards the foot. 12 o'clock is towards the head, towards the roof or towards the back, and 6 o'clock is anterior, that is into the disc space. Now I'm clearing this, I'm using an articulated curette, that is left biting, to remove the ligamentum fleum from the under surface of the facet joint. So that is the target number 3, that in the middle zone the under surface of the facet needs to be cleared first. I am also removing this part of annulus. I am trying to detach it from the L4 vertebral body, and I am trying to create a plane over here. Now this video has been fast forwarded at 200% speed, so things actually I am doing has been sped up here. Always we need to maintain hemostasis, and so that our vision is always clear. Now this is a right biting articulated curette, and I am trying to reach the tip of SAP, and this is where the tip of SAP is there, and I am trying to release the ligamentum fleum from there. So ligamentum fleum is attached at the tip of SAP, so it is very easy to remove it once we start from here. I am removing those ligamentum fleum, and I am basically undercutting the facet joints right here. These curettes are quite sharp, and uh, without using a burr or high speed instruments, we can easily cut the undersurface of the facet with these curettes. Now you can see this is the facet joint, the bony structure, and I'm just releasing the under surface of the ligamentum flavum, and you can see the bone is very well cut here with just our curettes. Now mind it that these patients are the bone in these patients are not very hard, and not always it is not always required to use a high speed instrument to clear these bones. The structure that you see now is the foramen here, and you can see that it is completely blocked. This is the foramen that is completely blocked. This is the pedicle of L5 vertebra, and this is the Wagner arch that we can see. And you can see that the under surface of the facet is here, and the foramen is completely blocked by the bulging disc. You cannot see neural structures from here. So what I'll be doing is I'll be removing the part of disc which is lying anteriorly so that we could create some space for us to work there. Always use a good cautery to achieve your hemostasis. If there's bleeding, you need to increase your pressure. Whenever we are working in this lower part of the foramen, there will always be bleeding. So we need to be prepared for that. I'm just readjusting my cannula, and this is the part of facet joint, and this is the foramen here, the left foramen. Now what I'm trying to do is I'm trying to create a plane between the dura and our disc, and as we are doing that we are encountering some epidural vein, and you can see here that our foramen is slightly opening up from this region. Again, small bites in which we can remove this part of disc, and you can see that how beautifully we have opened up the foramen dorsally, and this is the under surface of the ligamentum flavum that we have removed completely now. You can see this is the facet which we have been cut by our curette, and dorsally our work has been completed. There's not much dorsal work. Now all of our work needs to be concentrated on working on the disc. So now you can see this is our first glimpse of traversing root over here. After removing this fragment, you can see it right over here. This is our traversing root. So this is our root that we can see here, but there's still a lot of bulge over here. Now the articulated curettes are very useful in removing these bulges. That it is very atraumatic to our neural structures, and it can easily detach those the part of annulus from the upper end plate, and we can get a good decompression from there. Whenever you are using a radio frequency cautery, you must be aware that you should never uh, take it near the nerve roots, and so because these are powerful instruments and that can cause damage to our nerve roots. Now this is an annular cutter. What you are seeing here is I am removing this osteophytes at the lower end plate. Now that is the junction of the middle and the lower zone. And as you can see, these are hard calcified disc fragments that I am removing, mainly the osteophytes that have been removed from there, from the lower part of middle zone. Now in case of stenosis, the disc is not a single fragment, but it is a whole bulging entity. So we need to cut it to remove it. It cannot be just grasped and pulled out. It has to be cut into multiple pieces, into piecemeal, and then it has to be removed. The thing that I am doing now is I am trying to detach this annulus from the lower end plate of L4 vertebra. This is an annular cutter used to cut those part of annulus. You can see our nerve has been very well decompressed in the lower part of middle zone and the lower zone. Some part of disc is remaining here which will be subsequently removed. You must always be careful not to touch the dura when we are using a radio frequency probe. Now that is the upper part of the middle zone. This is towards the L4 vertebral body that we are removing, and I usually cut the annulus up to the midline, and that is the midline that we have reached. I'll just remove these fragments and achieve hemostasis over here. Whenever we cut annulus, it is most likely that it will bleed, and we should be ready with our radio frequency to tackle these bleedings. So I am working at the tip of SHP, or some the G node that I have been talking about. Now that is amalgamation of soft tissue, the disc, and the soft tissue at the tip of SAP over here. So that needs to be decompressed as well. This is the tip of SAP and the G naught lies over here. You can see bubbles that are from the fat from the exiting nerve. I don't need to go to the upper zone, so I'm not going there. I'm just removing the ligamentum flavum from the tip of SAP and the undersurface of the facet joint. You can see this is the undersurface, and I'm clearing those undersurface. As you can see that this surgery does not take much time. The whole procedure has been done in about 20-25 minutes, and you can see it's just a 12 minutes video of the whole procedure. So the stenosis surgery by transforaminal route is not very difficult, but knowing the target is quite important. You can see our traversing route is now very well decompressed in the middle zone, and just some remnants of the disc have been removed right now. You can see that the middle zone is quite well decompressed now. There's not much thing. Those sometimes there might be adherence between dura and the disc, and we may have to leave that part of disc with the dura over there. But in this case, we have been uh, successful. We have been able to successfully remove that part of disc, and dura is completely free, as you can see here. Now, at the edge of the lower zone, this is the ventral aspect of the the point where we need to decompress a ventral aspect in the lower zone of the dura. Now, this is the location which is mostly missed in open surgeries because we cannot adequately visualize these small structures. So now what I'm trying to do is I'm just scraping off all the osteophytes from the upper end plate of L5 vertebra, and this lower zone, the disc which was lying inferiorly, has been removed very well with that annular cutter. So our three zone decompression is now complete, and you can see that how beautifully the dura has been decompressed. The foramen has been opened, the facet joint has been undercut, and as you can see that this is facet joint, and I am just coming out, and so that's it. This is the end of the surgery. So this is how I do decompression of lumbar canal stenosis by transforaminal route. Main thing is to identify the cause of stenosis and to reach at each and every cause. I believe that transforaminal surgery can be very helpful in relieving this stenosis without doing much harm to the patient, without cutting much of the bone, and without using any implants. So thank you very much for your time for watching videos. I hope you liked my video, and if you have any question or doubts, do let me know. And thank you for watching.